we are trying to centralise the specialist services so that we can have longer consultant cover, so that we can have consultant cover at weekends and evenings and over the night, and that is to do exactly the same thing. If you are fortunate enough to need these services, you want the best chance you can have of having the best outcome you can have, and we will try to reduce the risk of you having a bad outcome. And for me, as a clinician, that's what these proposals do. I think the way we're going to achieve that is investing in local services.
We've got big hospitals being turned into clinics. Charing Cross Hospital is a hospital with 400 plus beds, and basically those beds are going to close, the A&E is going to close, the surgery is going to close, maternity is going to close, and you wind up with a giant clinic on that site. Now that is not a development I think most people reckon is an improvement in the access to services.
But that's the process of consultation. That's all built upon the fact that we completely need to redesign and make general practice and community services much, much better. Because one of the reasons why too many people are using hospitals much too often is just because they can't get access to GPs, they can't get the care and support they need from district medicine. And we want to rectify that. So all our plans around improving primary and community services first, doing that and building upon that over the next 2 to 3 years before we begin making changes in hospital. Because that way we can absolutely have the infrastructure in place to produce better care, reduce the work in hospital, and only when we've done that can we then begin changing hospitals.
There are no details. There is no plan to provide these alternative services. This is an enormous gamble, it's an enormous chance being taken, and it really defies belief that we've got to this stage. We still have no clue as to what services would be provided, where they would be, how they'd be managed, or what resources would genuinely be actually there, and what happens if they don't come on stream at the right time, and what happens if some of these plans don't kick off smoothly, as everybody seems to be hoping. We're also told that there are no cuts in the NHS. There are only savings. There are only savings. Are there any efficiencies? I'll tell you what, it feels like a cut when you actually see what's coming down the line. And when you read the actual document behind the consultation document, not the consultation document itself, that makes very clear that NHS North West London has to save £1 billion out of a £3.5 billion budget. That's a 28% cut by 2015. In real terms. Now, okay, maybe they're saying that they're going to have to save this in order to plough it into additional resources. The reality is that all these things that are being added up result in less and fewer staff.
We spend more on our buildings than we do on caring for people. And what we're trying to do in redesigning this is we're going to be spending less money on estate, the buildings, because we can redesign a local hospital that needs a smaller space, that releases capital, and that allows us to spend more money on patients, and particularly employing more doctors and nurses in the community to produce better care.
There are going to be far fewer staff delivering services. I'm not sure how this fits with improving the quality of care in North West London. Far fewer staff. The objective is to get rid of 5,000 staff by 2015. 5,000. Almost 4,000 of them clinical staff who deliver the quality services that we're actually talking about. I don't understand how you're going to actually deliver all these improved results with so many fewer staff while the demands on and the health pressures on the NHS to continue to escalate. There's going to be far less actual hospital treatment. As I said, if you add up the sums on page 39 of the consultation document, you add those sums up and you realise it's 100,000 plus 29,000 plus 19,000 fewer admissions to hospital. That's 148,000 a year fewer people going to hospital. That's utterly enormous number. That's 3 hospitals worth of patients not going to hospital. Where are the plans as to where they're going to go instead? And what's going to happen to those who turn up at these urgent care centres and actually need to be in hospital? Who is going to transfer them? Because they will not be transferred by the blue light ambulances, who they've got timings for apparently, and they appear to have worked out how long they might take. But if you're turning up in the wrong place at one of these urgent care centres, you do care they can't provide, who's going to take you to hospital, and how long is that going to take, and what impact is that going to have on the services, both in the hospital and in the urgent care centres? There's 100,000 fewer attendances at A&E they want, 600,000 fewer outpatient appointments. How does that contribute to improving the quality of care? This is in hospitals. Okay, so we need 500,000 additional outpatient appointments apparently in the community. Where in the community? Are we going to meet around a bus shelter?
Are those figures right or wrong?
No, I don't think they're right.
Well,
All right, tell us. Tell us what they are. What are they? What are they? What are they? It's in there. It's in there.
So we are expecting that in 3 years' time, the NHS in North West London will employ more staff than it does now.
What?
One of the thrusts of these proposals, as Mark said, is to aim to spend less of our money tied up in very expensive buildings and more of our money to employ staff. So you will see that in the out-of-hospital strategies, which we accept are not yet completely perfect, but they are setting out a very clear vision about how we wish services to develop over the next few years.
I'm trying to improve the chances of a good outcome and reduce the risks of a bad outcome.
what this tells you about is it's a little bit of a graph, and it shows that the longer you're waiting around in an absolute emergency department to get sorted out and someone to dive about what's wrong with you, not surprisingly your risk of having problems staying in hospital for longer goes up. And the other problem is that what they're proposing is they're proposing an urgent care centre, and these are staffed by GPs and nurses. Now, often they are good, but they are used to seeing a range of conditions that GPs and nurses are trained to treat. Okay. The problem is there's a whole list of conditions here that actually an urgent care centre, when it doesn't have specialist services on site, like you have at Charing Cross, for example, like we have at Ealing, that actually this list of conditions here, which includes cancer with a fever, includes people with a significant history of mental health problems, or there's a whole list of things on here that actually an urgent care centre needs backup for. Now the problem is, if you then present to one of the urgent care centres and you don't know what's wrong with you, do you, necessarily, and you go in there and they can't sort out what's wrong with you, you will then have to wait until you go to another place. Now that's all right if there's not too much wrong with you, but if you're of the degree that you need to be admitted to hospital and you look at this graph, you can see that waiting around really doesn't do you any good. Now they'll say that actually what they need to do, and they are looking into this, they know it's a problem, they'll say, well, what we need to do then is we need an ambulance to take you from the urgent care centre to your nearest major acute hospital. Now, that means if you look at some of these hospitals, I give you the figures from Ealing, up to 50 patients a day come through the urgent care centre, and they cannot be sent home, they have to be admitted to hospital, they have to go to an A&E. So we're talking about, in some of these sites, up to 50 people a day extra ambulance journeys. Now, the blue light ambulance times, they've looked at those, but what they haven't factored into the blue light ambulance time is the extra impact of all the other journeys that will have to be done to get people who need to come into hospital, need to go to their nearest A&E, to there within the time. Because remember, the clock is ticking.
But it's about reducing risk. And for me, these proposals are doing the same thing. We are trying to centralise the specialist services so that we can have longer consultant cover, so that we can have consultant cover at weekends and evenings and over the night.
They know that the big risk is they can't deliver these community services. That was in their risk assessment. What have they done about it? Nothing. If you look at the column for mitigating measures, none whatsoever. Who's in charge? Don't know. To be confirmed. This was the 7th of September. More than halfway through the consultation process, and they still don't know who's in charge of sorting out what happens if the central part of their plan goes belly up. Now, who wants to be taking that risk with local health services?
My concern is the way that this is being done. It doesn't really offer people real alternatives. It gives you sets of paired hospitals, and it has set GP against GP. This whole process has set GP against GP, GP against hospital. and really disturbingly hospital against hospital. And I think
the fact that some of the most deprived populations are served by the hospitals that they're proposing to run down. It's almost like they've followed a map, right? It says main clusters of health deprivation, the hospitals are concerned, Central Middlesex, Hammersmith, Ealing, Charing Cross. Well, hang on a minute, aren't they the very ones that are going to lose their hospital services? So the people who are in the most deprived areas are going to have to travel elsewhere to access their treatment.
Any change to hospitals make people very concerned because they need to be convinced and assured that services are going to be better at the end of it. And part of this discussion is to try and give you some of the evidence to assure you that, first of all, there is a need to concentrate emergency services.
The roadmap simply isn't there, the investment programme is not spelt out, and we just cannot have security over at the present time the way it's articulated to the public. The second is around capacity, particularly hospital bed capacity, but a lot comes with that, the complexity of hospital work along with that. This may or may not be gained. 1,000 bed losses out of 4,500 needs contingency plan. There's a big risk here. We may not manage in the community to save those 1,000 beds. So where's the contingency plan? Put it before us. In the public, my patients need to know, I need to be able to tell them exactly what's going to happen if we don't save through hospital efficiencies those 1,000 beds.
And part of this change is to ensure you have more consultant surgeons who can do abdominal operations, more consultant orthopaedic surgeons, as Mark said, who can do the upper limb and lower limb work, more consultant emergency doctors and physicians who will be available for longer periods of time, 7 days a week, so that they can see patients and deal with them immediately, and this will deliver better outcomes. But to do that, we have to concentrate the services.
Plan change by 2015, minus 13.8% full-time equivalent, minus 12.6% clinical staff, proportion of clinical staff also to go down by 17.9%. These are your figures. And if you get the calculator out and work out how many people that is 1,754 jobs to go this year, right? 5,629 by 2015, 3,994 of which would be clinical staff. Now, even if you do manage to somehow, in somewhere, appoint 900 people to work in these places we don't know where, in these community services you haven't yet decided what they are, even if you do appoint 900 to do that, you're still 3,000 down on clinical staff alone, plus all the other staff that also do useful jobs in the NHS will also no longer be employed in the NHS in North West London. It's a total fabrication to say you're going to employ more staff in 3 years' time than you do now. It's just not true.